Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Breast Cancer Screenings, When and Why, presented by Dr. Bettina Kurkjian, OBGYN with Washington Township Medical Foundation. Dr. Kurkjian is a board-certified gynecologist. She attended UC Irvine College of Medicine and completed her residency at Kaiser Oakland. Working together with her patients, Dr. Kurkjian strives to reach the best possible solution that meets the patient's individual goals and needs and is committed to providing women with the best health care possible, both medically and personally. And now, please welcome Dr. Kurkjian.
Thank you, everyone, for joining us today to talk about breast cancer screening. Thanks, Christy, for the great introduction. So why are we talking about this? Well, unfortunately, about 13% of us will develop breast cancer, about 1 in 8, in our lifetime. As you can see, female breast cancer does account for a pretty high percentage of new cancer cases, about 31%. While not the leading cause of cancer deaths, it does come in at about 15%. Breast cancer incident rates in women have been rising a little bit, about 0.5% every year since about the mid-2000s. So definitely something that's on our minds. So the good news is that we are getting better at detecting and treating breast cancer. As you can see from this chart, over about the last 30 or so years, the 5-year survival rates have gone up for women about 25% or so, or 15%. So not bad at all, but definitely we've been making strides both in detection and treatment. So let's shift gears a little bit. I want to talk a little bit about breast anatomy, just so that as we go through the rest of the conversation, where we understand the different parts of the breast, you can see that the breast includes the lobules. This is where milk is produced. And the breast is really an amazing organ in the human body. It undergoes really dramatic changes throughout our lifespan, especially related to lactation. So the milk is produced in the lobules. It flows out into through these ducts out to the nipple. There's also the areola, which is this darker portion. This has sebaceous glands that produce substances that lubricate the breast during breastfeeding. And then also there's fat in the breast, and not shown on this picture, but also underneath the in the armpits and up at the clavicle, there's lymph nodes that drain the breast. And most breast cancers do arise in the breast ducts. So many women will notice breast changes, especially related to things like menstrual cycle, exercise, sometimes caffeine, complaining about feelings of breast tenderness, maybe some pain, or even feeling like their breasts get lumpier at different times in their cycle. And these changes are really common in premenopausal women, and we refer to these as fibrocystic changes. They can be really bothersome, but generally it's not a health problem, so it doesn't really require treatment, and it's not something that we really need to get too worried or concerned about. So let's talk about screening. So when we think about breast cancer screening, what's our goal? What's a good screening test? So a good screening test is one that detects disease in the preclinical state, and what we mean by that is at a time where there's no signs or symptoms that would otherwise lead you to go in for testing. Of course, we also want our screening test to lead to an improved outcome. So if we're doing a test but we have no treatment for the problem, then that probably isn't going to be a really good test for us to do. Of course, we want it safe to administer and reasonable cost. So as we're talking through these types of screening that we have to offer for breast cancer, we want to keep these criteria in mind. So what do we have available? Well, we use breast self-exam and clinical breast exam, mammogram, ultrasound, MRI, and thermography. So we'll talk through each of these things in terms of pros and cons and how we use these different techniques. So breast self-exam and clinical breast exam, I do encourage women to do self-exam and of course come in for their yearly breast exams with their providers. Breast exam, it's convenient, especially self-exam. You can do it in the privacy of your own home. There's no cost or very low cost, painless, and easy to perform. Self-breast exam, it's something that you can, really master pretty quickly and get the hang of it. Unfortunately, self-breast exam probably doesn't improve detection or survival of breast cancer. Clinical breast exam performs a little bit better, but it's really not sufficient as a primary screening tool. It's useful in conjunction with other tools, but the problem is that we'll often detect cancer at a more advanced stage with clinical breast exam. So often my patients will say to me, I'm doing my breast exam, I'm coming in to see you, you're doing your breast exam, I don't want to do any other screening, you're not finding anything. And so I always like to say, this is a great thing to do, but it really doesn't replace other kinds of screenings in terms of detection of breast cancer. But if you are doing your breast exam and you see any of these changes, such as a discharge from the nipple, you feel a lump or a knot, you see changes in the size or shape of the breast or the nipple, changes in the skin, these are things that you may want to take mention of and go see your doctor for. I really want to say not all of these are signs that are indicative of a problem. Some of these can be very benign, but definitely should be checked out and not ignored. Okay, so let's talk about mammograms. Mammograms are really the gold standard for screening. So why is that? Well, when we think about mammograms, let's kind of think back on our screening, our criteria for a good screening test. It does detect the disease in the preclinical state. So often, it will pick up a breast cancer before we can feel a lump. Early detection leads to better outcomes, so we like that. It's very safe to administer, and it's fairly reasonable cost as far as testing goes. So what exactly is a mammogram? So a mammogram uses low-energy X-rays to image the breast, most of our mammograms now are performed using digital technology, so we don't use a lot of those, kind of old-fashioned X-ray films that we were all used to seeing before. There's a detector that converts those X-ray signals into signals that are sent to the computer, and then the computer generates a picture for us. You probably have heard discussion around different types of mammogram, conventional versus tomography, or tomosynthesis is the other term you may have heard. So I just want to talk a little bit about 2D versus 3D, or conventional versus tomography. So from your perspective as a consumer, as a patient, the technique is going to look very similar. The radiation exposure is similar. The discomfort or lack of discomfort is going to be the same for both of these methodologies. The difference is in the pictures that are generated for the radiologist, which is really key, because the better the picture, the better able the radiologist is to either detect a cancer that's there or not get sidetracked by something that looks like a cancer they're not really sure of. So 2D mammography takes pictures, one picture from the side, one picture from the front, and creates a 2D image. 3D tomography takes multiple X-ray pictures at different angles, and then the computer makes a comprehensive 3D image for us. And 3D tomography is really becoming the gold standard in terms of mammogram screening at this point. At Washington Hospital, all of our screening mammograms are done on our 3D machine because the radiologists have been so impressed by the pictures that they're getting and their ability to use those pictures to make good decisions. So just a little quick talk about radiation exposure. So a lot of women are concerned about the radiation exposure with a mammogram, especially because we're asking you to do mammograms every year, every couple of years. So radiation exposure is about what you would get as background radiation flying from Los Angeles to New York. So pretty minimal. Okay, so let's talk about screening intervals. So do not try and read this chart. I put this up here only to show you how complex this issue is in terms of when to start screening and how often to screen. So you can see that there are multiple organizations that have weighed in on this topic, and their recommendations are quite nuanced and complex. And so it makes it really confusing for you as the consumer to understand what is the right guideline for you. It makes it challenging for myself as a clinician and for my colleagues to be able to adequately counsel you about what the right move is. So generally, though, I can say that everybody agrees that mammogram is good at detecting breast cancer. So nobody is arguing with that. Everyone says, yes, mammogram is good at detecting breast cancer and good at early detection. The reason that these different recommendations come out, though, is because there's also a really important issue, which is the issue of false positives. So false positive is where there's something that looks like it is a cancer on the mammogram, but then on further investigation, either another check or a biopsy, it turns out to be not cancerous. And so when we think about a screening test, we think about is it safe to perform and is the cost reasonable? You know, when you start adding follow-up screenings and you start adding biopsies and all of that, that changes the dynamic around that a little bit. So organizations looking at population health are trying to kind of make that balance between detection versus cost and safety. And sometimes when we think about things from a population level, it doesn't always translate into what's right for an individual woman. So what I encourage women to do, and what I tell my patients, and what we do at Washington Township Medical Foundation is, we encourage our patients at 40 to have a conversation with their provider, and if appropriate, to start yearly screening at age 40. But I think the most important part of that recommendation is that conversation with your provider. You know, risk is individualized, so different women have different risks for breast cancer, and we all have different concerns about breast cancer and the impact of potential breast cancer on us as individuals and our families, and what we know with our families and our friends. So the most important thing is really have a conversation with your clinician. Talk to them about what your own risk is, what your own concerns are, and then come up with the right screening interval that works for you and meets those needs. So let's talk about some other ways technology that we use to think about breast cancer screening and testing. So MRI is a really good companion imaging test, companion for mammogram. We use it for women who are at high risk for breast cancer. We don't use it as primary screening for a couple of reasons. It is very good at detecting breast cancer. In fact, it does detect some cancers that aren't found on mammogram, and it doesn't have X-ray exposure, which is also why people like it. However, it does require injection of contrast material. It's significantly more expensive than mammogram. It takes longer. The study takes longer. Positioning can be uncomfortable. And really importantly, the false positive rates are higher with MRI compared to mammogram. So it's, which results in more biopsies or more procedures. So it's a great companion tool for mammogram. It's a good tool to use for women who are very high risk, but probably not where you want to go to first for screening. Ultrasound is another great imaging technology that we have, and it's also complementary to mammography. We use it more as a diagnostic test than a screening test. It's very good at distinguishing, say, for example, a solid mass versus a fluid-filled mass. But it doesn't show those microcalcifications that are present, that can be present in early breast cancers, which is one of the key things we look for. And you don't get as good an image deep in the breast. So again, it's a great complementary study for mammogram, but probably doesn't really perform well enough as a primary screening. And then lastly, thermography. Thermography is a test that is used that uses an infrared camera to detect heat patterns and blood flow in the body. It has not been shown to be effective as a standalone screening tool to detect early breast cancer. It doesn't replace mammogram, and it is not where I would go to as a first line for screening. Okay, so we've had our mammogram. What are some things that we might find on our report? So one of the things that's reported is if you have dense breasts. So what does that refer to? Your breast tissue is called dense if you have a lot of fibrous or glandular tissue and not much fat. And we don't really know, there's no specific reason why some women have dense breasts and other women don't. We know it's more common in younger women, women who have a lower body mass index, but we don't really know exactly what drives that breast density. We do know that it is a risk factor for breast cancer. It does increase your risk a small amount if you do have dense breasts. It's not significant enough that you're recommended for additional screening, though. Still, even for women with dense breasts, mammography is the recommended first-line screening. Sometimes on the mammogram, something will trigger the radiologist to be concerned. They may ask you to come back for a second look. Sometimes they will recommend a biopsy. A biopsy is basically where we remove a small sample of the breast tissue to be sent for further testing. We used to do our biopsies surgically so that you'd go to a surgeon, you'd have an excision made over the area in question, and they'd remove that area. Now we have moved to corneal biopsies, which is basically where the radiologist numbs up the area. So it's done in the same radiology suite where you have your screening test done. They'll numb up the area, and then they'll use a small needle or probe to remove a sample from the area. They will use the imaging technology to locate that abnormal area. So you may be recommended for a biopsy using ultrasound, mammogram, or MRI, depending on where the radiologist is best able to locate the lesion. Not all breast masses are cancer. There are non-cancerous masses that will pick up either on exam or on mammography or ultrasound. One of the most common of these is what's called fibroadenoma, which is a solid tumor, which is commonly found in younger women. And it's not generally associated with an increased risk of breast cancer unless there's other components of the fibroadenoma. Breast cysts are also quite common and don't really require any treatment unless they're symptomatic, such as causing you pain or that kind of thing. It's really not a one-size-fits-all for these non-cancerous breast masses. It really depends on, what's recommended will depend on how it looks on imaging. Sometimes they'll just follow it with repeat studies. Sometimes it would be recommended for biopsy. And treatment afterwards also depends on a number of different components. So again, when one of these issues are found, your radiologist or your physician will talk with you about what any concerns about it and what the appropriate follow-up is. Sometimes we will get a report back that doesn't show invasive cancer, but it's also not normal. These terms you may have heard about, hyperplasia or carcinoma in situ. Hyperplasia basically means that there's more cells than should be there, either lining the duct, which would be ductal hyperplasia, or lining the lobule. This is a benign breast condition, but it is linked to a moderate increase in breast cancer risk. Carcinoma in situ is actually where the cells are cancer cells, but they haven't spread, so they're either localized in the duct or localized in the lobule. So this is considered a non-invasive or a pre-invasive breast cancer. And as I mentioned, both of these conditions are associated with an increased rate of invasive breast cancer. So, abnormalities that are in the lobules tend to be a little bit lower risk than abnormalities that are in the duct. So usual treatment for these is surgical excision. We remove the area in question, and then sometimes you'll be recommended for what's called chemoprevention, which is taking medication to decrease your risk of developing invasive breast cancer. So breast cancer, it's such a complex and nuanced topic. It's really beyond the scope of this particular talk. Treatment outcomes are varied and really influenced by multiple factors, such as grade, which is how the cells look. Do they look more like normal cells, or have they progressed more toward cancer cells? And the stage, which is how far the cancer has spread, stage 1 being confined to the breast and stage 4 being spread to other organs. And in general, you can see from this slide that stage 1, the survival rates for stage 1 are really improved compared to stage 4. You can see a gradual drop off, from stage 1 to 4. So this is why, this slide alone, I think, shows you why we are so passionate around breast cancer screening, because we do have a great tool in mammography to detect early breast cancer, where we can treat you and really have great outcomes. The cartoon on the right side, don't mean to disparage the men in our lives who are, wonderful supports, but I think many of us do know women who have been diagnosed with breast cancer, who really are just, facing this really challenging situation and just powering through. And so, we want to do whatever we can to support them. So what can we do to decrease our risk? Well, some factors are beyond our control. For example, as they say, you can't choose your family. So family history is something that we're born with, right? And age at menopause is also something we can't influence. And as much as we all like to think we can control aging, we really can't. That's another risk factor that we can't control. But there are certain things we can control. Maintaining a healthy weight, exercising, decreasing alcohol use can mitigate your risk to develop breast cancer. So, what I tell my patients about this is, we're all in a different place in terms of our, how we feel about our weight, how we feel about our eating pattern, what we're doing with our exercise. So don't beat yourself up. You are where you are. Start with where you're at. Choose something small that you can do, something that you can commit to. Maybe it's one night a week you're going to, have half your plate be, vegetables. Maybe you're going to go for a 10-minute walk, every day at lunchtime. Maybe you're going to grab your, spouse or dog or partner and, go for a walk after dinner. So start small, choose something you can commit to, master that, and then when you've built that nice healthy habit, add something else on. And over time, we can all do whatever we can to decrease our risk. So lastly, a final reminder. I know it's not October, but for me, every month is Breast Cancer Awareness Month. And so if you're due for screening, please call, make that appointment, go in for your screening. If you're on the fence, have a conversation with your doctor. Be open about, what your family history is, what your risk is, what your concerns are, both about screening and about breast cancer, and come up with a plan with your provider that makes sense for you, that feels good for you. I put some resources at the bottom of this slide. At Washington Hospital Women's Center, we have a really wonderful breast health center. As I mentioned, we're doing exclusively 3D mammography here. We have a wonderful nurse, Christine, who helps our patients navigate through their care in the center. So check out our website. I really like to point everybody toward the American Congress of OBGYN, ACOG.org. That is the source for any information on women's health, comprehensive women's health. They do a great job with their message, with their information, their educational material, and then of course the CDC. So thank you so much for joining me, and I'd love to answer any questions.
Okay, thank you, Dr. Kurkjian. That was a wonderful presentation, and we do have some questions. The first question is, my mother has breast cancer. Should I do genetic testing?
Yeah, so that's a great question. So the sort of short answer is, not every woman who has a family history of breast cancer needs genetic testing. Generally, there have been 2 breast cancer genes that have been identified. You may have, heard the terms BRCA or BRCA1 and 2. There are a number of other genes that are being uncovered, shall we say, and linked to also breast cancer risk. But the BRCA genes are the 2 that are the most well known. These are what we call tumor suppressor genes, which means we all have this particular gene, but when it's not working properly, then it doesn't suppress the functions in the cell that stop it from developing cancer, and cancers develop. So what we see for families who carry the BRCA genes, it's only about 15% of women who have breast cancer actually fall into this category, so pretty small percentage. And what we generally see is that women have, there are multiple family members with breast cancer, also associated ovarian cancer, and family members are pretty young when they develop it, in their 40s or even younger. So, if you have one family relative, a mother or a sister who developed breast cancer, say at age 55, 60, 70, and no other family history, it's very unlikely that you are your family has the BRCA gene. If you have multiple family members with breast and ovarian cancer, especially who develop it at a younger age, then there's a little bit higher chance. So what I recommend for people is to instead of just getting the testing right off, if you have this available to you, see a genetic counselor, talk about your family history and your risk, and understand what might be the best testing strategy for you or your relatives.
Okay, thank you. Another question. In your presentation, you mentioned that breast cancer screening for mammography starts around the age of 40. And what would your recommendation be for those under 40 to start self-examinations at home?
Well, so I encourage everybody to do self-breast exam. Even if you're not in the category where you're recommended for mammogram screening, I think self-breast exam is a great way to understand what is the normal anatomy of your breast and what your own lumps feel like. So what I tell my patients is, don't worry too much about, are you feeling the lump that you're feeling? Is that something you need to be worried about? Is that cancer? Just get used to your own normal lumpiness, and then if you feel something that is different that you haven't felt before, even if you're saying, well, it doesn't feel hard like a pebble, and she told me only to come in if it feels hard like a pebble. No, I say, if you feel something that's different, come in and let me check that. Many women, especially younger women, under 40 or under 50, will have lumpiness of the breast, and that can vary during the menstrual cycle, and it can really kind of freak you out when you're like, oh, I found a lump, right? So it's really about getting used to understanding what your normal breast feels like, and then identifying anything that's different from that.
That's great. I like get used to your own lumpiness. That's a good one. So last question. At what age do I stop screening?
Yeah, so that's a great question. There isn't really any specific guidelines around that. If you remember that really complex slide that I showed you that had to do with when to start screening, the slide that has to do with when to stop screening, or the chart that has to do with when to stop screening, looks exactly like that one, full of lots and lots of words. So basically it comes down to sort of individual decision making, and it really has to do with what are the other things that are going on for women from a health perspective, and generally, if you and your doctor feel that you have a reasonable life expectancy where, if you detected an early breast cancer, you would be eligible for treatment, want to have treatment. Go ahead and screen. I have some patients who say, at my age and with my health, even if there was an early breast cancer, I know this isn't going to be the thing that gets me, and I just don't want to screen. It's not worth it for me. I'm not going to do anything about it. I have other patients who are, into their, late 70s, 80s, and say, yeah, I want to know about this. I'm living a vital life, and an early breast cancer I'm going to take care of, and I'm going to have that treated, and we'll continue to screen. So again, it really is about that conversation with your doctor. What are your goals for screening, and how can we help you meet your goals for screening?
Thank you. So this does conclude our program, and thank you again, Dr. Kurkjian, for this insightful presentation, and thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.